Thanks, everybody. That was an amazing presentation. What we've done here is just prepared some questions that we think might possibly be in your heads, and we're certainly going to gather all the other questions that you're giving us. But we've asked each of these folks to prepare to answer just another or one or two additional questions in a short period of time here. And I'm going to go in the same order that we went. So, Dr. Carmen, I'm going to start with you. I think we heard a lot in the last hour about how badly things can go for us, for our loved ones, for our families and friends if we don't do this planning. But one of the things that has struck me is that we don't often think about the impact on our healthcare providers of us not doing our proper planning. We all know here on the Sunshine Coast, we're struggling to attract and keep healthcare providers. We certainly don't want to scare them away anymore. So, Carmen, I wonder if you could just speak briefly about what you think the sort of effects are on the healthcare system of us not doing our proper planning. And there's a microphone that you can pass down there. Thanks.
This is oh yeah, okay. Sorry. Thanks for the question. So I think something that's come up throughout this presentation is a scenario actually that Chloe highlighted in one of her cases with the first gentleman, say, coming into the ER. We don't know much about him, and he's had a catastrophic event, can't speak for himself anymore. And then, trying to figure out who the decision maker is. And what can sometimes happen, which I would think is kind of worst case scenario, is you have decision makers coming in and their views and values do not align with the recommendations that we are making as medical professionals. So, if someone is there just because a treatment is available doesn't mean that you should have it. Because often, sometimes, especially really aggressive treatments like getting a tube down to help you breathe, which is called life support, or getting CPR in your chest to try to get your heart started again, or electric shock to try to get your heart started again. Like, those are very, very aggressive. And those sometimes can be successful, often or not. Especially with our population, older, a lot of chronic illnesses. You often don't leave the hospital with the same meaningful life you had when you came in after having interventions like that, if you leave at all. And so you can imagine how distressing it is for a family member, loved one, decision maker coming in to a situation like that, seeing their loved one very sick, and then on top of that, having to make life or death decisions for them. And so for us as providers, I think we try to make the recommendations that are gonna do no harm, right? So that's one of the oaths that we take, is do no harm. And I think there can be a lot of moral injury when we are making these recommendations and then we're getting a lot of pushback because the values don't align. So I think those are the cases. I'm speaking for myself, but I think I'm probably speaking for a lot of healthcare professionals. Those are the cases that we go home thinking about, perseverating about. They cause a lot of trauma, not only for the decision makers, but for us as healthcare providers. And I just can't highlight more of that moral injury. And I think as providers, if that keeps happening over and over, it really does take a toll. And I think it can contribute to things like burnout or not being able to sustain your job, maybe leaving the field. Those are kind of worst case scenarios. And it's nice to know there's the ethicists to come in and help, but it really is a gift to everyone, including your healthcare providers, really thinking about what your wishes are and making a plan and documenting your plan beforehand. Just you save your team and your loved ones a lot of distress.
Great answer. Thanks very much, Carmen. Pass to the next Carmen. The question we have about the legal matters, what if somebody doesn't have a lawyer or can't afford a lawyer? What would be their next step to get their affairs in order, Carmen?
Come to seminars like this. First of all, the legal cost for these papers can be a significant barrier, and in preparing for this, I was looking to see what resources were available. And I have a fairly good knowledge of the area, and on the internet it was fairly difficult to find out. But coming to this MedTalks today, if you cannot afford a lawyer, one of the first things I would suggest is that My Voice book. Because in the My Voice book, it has the Section 9 that you can fill in. It has the Section 7 representation agreement that you can fill in. They can't be super customized, but you can pick somebody. It's very simple agreements on government forms where you can get that done. Also, if in the resources, there's a handout in the lobby that refers to the NIDUS site. That's NIDUS. They have forms where you can type in on the computer the representation agreement, the Section 9 and the Section 7. With the power of attorney, I strongly recommend, if you want it to be legally enforceable, have a lawyer or notary draw it up. As a lawyer, I will notarize Section 9s and Section 7 representation agreements. I will take a quick proofread of them, make sure they are filled out correctly, because I know a lot of people can't afford them, and then I'll just charge a notarizing fee, because I know it's better to have a hand-filled out document for Dr. Carmen than no filled out document. There is also in the lobby, there's 2 or 3 other resources where you can get free information. And I forgot all their names, but I saw them all in the lobby. There's a handout, a single-side sheet. Definitely pull it out and you can get resources there. What's really important is follow instructions when you are filling out forms. If it says full name, that is not Bob Smith, it's Robert John Smith. And so fill out the forms carefully, and most of them will work. The power of attorney, generally speaking, the hand-filled out form will not work.
Should I add to that?
Sure, by all means.
Awesome. Because a lot of the folks that I work with aren't in the financial position to actually be able to see a lawyer. And I know that Cathette Powell, I was speaking to the social worker at Home Health there, and she actually connected with Seniors First BC. And because she had such a big grouping of folks who really needed help with advanced care planning, they actually scheduled for a lawyer to come to that community and do sort of like a road trip around and go and see folks and do this paperwork with them for free. So, I mean, I don't know why that couldn't be possible here. Just a thought. And again, just emphasis on NIDUS. If you're able to get on a computer and have a look at nidus.ca, there's also a person or people who work at NIDUS. It's a not-for-profit. And they are the gurus of advanced care planning. You can call them, email them for clarification. They will speak to you on the phone, and it's a tremendous resource. Again, those forms, you can just go in there and print them off. They also have a registry. So if you're not sure what to do with the paperwork once it's done, they have a registry where you can put definitely your representation agreement, but I think other legal documents on there so that they can be found at later dates.
Good. Hang on to it. You're next.
Sure. Okay.
I was asked to ask this question. We scheduled our Med Talk today around lunchtime in the hope that it would also provide an opportunity for those among our community who are still working full-time, which most of us are not, to come and listen to this Med Talk. And I was asked by one of them to ask you this question, Chloe. If I'm the son, daughter, grandchild, whatever, how do I get my parents, grandparents, elderly neighbor to talk about ACP? What are the resources? Who can help me get this conversation started if they're saying, no, I'm fine?
Yeah, really good question. Depends if your daughter's a social worker and bullies you into it. No, but know your audience, because everyone will take that in a different way. And so I think there's different ideas of bringing things up. One could be like, hey, there's this great 37-minute documentary on Netflix called Extremis, and it's exactly in an emergency room and ICU and talks about what happens and these
incredibly stressful situations families are in, trying to make, these life-sustaining or possibly end-of-life decisions for family members and what that's like. And just to start the conversation, or I like to throw a lot of, hey, my friend's mom just had this happen to her, and, oh my goodness, I hadn't really thought about asking you, but what would you want to do in a situation like that? Because I'm not really sure. So just like trying to casually bring it up. I'm also a fan of asking consent, even with, family members and neighbors. Like, I was just thinking about this. Is now a good time to talk about it? Or could you let me know when you might want to talk about it? Because we can't force ourselves on people. Again, these are optional. These are all optional. It's voluntary. But I think if you come about it with a gentle approach, it can go a lot better.
Great, thank you. And all the way down to Kim, please. Kim, I think I'm not alone in having been unaware that VCH had ethicists, and now I actually can say the word and know what it means. So thank you for that. And my question is related to that. I know that you're based in Vancouver. If someone, a patient, a citizen, wanted to talk to an ethicist about these matters, would they start with you? Would they call you? Or is there someone here on the coast? Do you want to talk a little more about that?
Yeah, for sure. And I know the term ethicist is a tough one. It doesn't roll off the tongue very easily. And often people confuse me for an esthetician, which I also can't say.
Can you do my hair and makeup too?
So sometimes I wonder, maybe that's the route I should have gone. But yes, well done. Yes, I would be the first on-call ethicist for all of our, again, VCH sites within the Sunshine Coast and all of our coastal communities of care. So we kind of have more regional coverage for ethicists. So while I'm based out of the Lionsgate Hospital on the North Shore physically, I'm not that far away. So I'm always open for a trip over if there was more need for physical in-person events or consultations, or, a family meeting or something. We can always come over. But that being said, we do have, technology now, and we can have either a teleconference or the phone or a Zoom call if you have, a website available. So that's for an ethicist. But even those local to the hospital, especially people like Chloe or Anish, who's also in the audience, or social workers, are really also well-versed in ethics, and they are dealing with a lot of the ethical issues as well, and they might loop us in if that might be like a go-to starting place, like a familiar face. But absolutely, you can always reach out to me individually, and happy to connect. And also our email is ethics@vch.ca. You can send an email there, and then we kind of triage who would be best. It would likely be me, but if I'm not available, there's actually 8 ethicists across VCH now, and some of which are part-time ethicists, but there's always someone available.
Great. Thank you very much. I can't see where my team is, but Jane and Sarah, do you want to start bringing up questions from the audience? There you are.
I thought you'd never ask. It's working. Okay, thanks everyone for your questions, and we'll try to get to as many of them as possible. So, Carmen Sombrowski, we have several questions just to clarify the difference between a power of attorney and an enduring power of attorney. And could you just do a high level on that again?
So I may have interchangeably said enduring power of attorney and power of attorney. I practiced forever. When I started, they were powers of attorney. Whether I said enduring power of attorney or power of attorney, I was referring to an enduring power of attorney. And an enduring power of attorney means it endures subsequent incapacity, whether that capacity is mental or physical. So that means as soon as you lose capacity, the attorney doesn't die, or the ability for the attorney to sign papers doesn't lose the ability to sign papers. That's what an enduring power of attorney is.
Okay. And does it make a difference if someone's appointed someone as power of attorney? Do they need to be resident in Canada? Could they be from another country?
They can be a resident from another country. Often, if you are considering an attorney from the United States, you should be fully aware that under American law, the attorney may have an obligation as agent to disclose all of your financial affairs to the IRS, and if they do not disclose them, there can be significant penalties. As to other countries, most countries, I believe, do not have the same law that the Americans have. So yes, you can have your American child be your power of attorney. However, they have to disclose your assets to the IRS.
Okay, we will be doing that. So moving on. There's a question of power of attorney or representation agreement. When you're unsure of the most suitable person to relay and represent your wishes, is there one better than the other?
The people that you select for the representation agreement, you have a scheme if you do not select someone, and that Carmen Gouja set out. For the power of attorney, if you do not pick anybody, the public guardian and trustee will be looking after your affairs. When you pick people, it should be people that you trust, people that you are familiar with. You often see where people think they have to pick family members, a niece in Ontario that you haven't spoken to for 10 years, a friend that can't even keep their financial affairs in order, never mind somebody else's. It is not easy to pick people. Often on the Sunshine Coast, I've been seeing more and more where for the representation agreement, neighbors are picking neighbors because they do not have close friends, they do not have close family, or they have no family. And they are using the community as a support network so that they can step in on the representation agreement or the Section 7 representation agreement. For the power of attorney, you can pick financial institutions if you do not have people you trust. You can pick lawyers, accountants, you can pick professionals and pay them to be your power of attorney. If you have trust issues with your children or with people that you pick, in certain circumstances, you may want to just do an RA7 or the Section 7 representation agreement so that your day-to-day finances and the easy stuff can be looked after, but people don't drain your bank account.
Right on. Thank you. Dr. Carmen, this might be in your wheelhouse. There's a few questions about, I'd like to initiate an advanced care plan, but I don't have a primary care doctor. So I have no one to consult with. What should I do? And maybe you can chat a bit more about Greensleeve and as well any other resources inside our constellation.
Yeah, great question, because so many people are in the same boat. So actually, Sunshine Coast Hospice has arranged with the Sunshine Coast Division of Family Practice to try to have a referral program for those who don't have a family doc so that they can still have their documents and have an advanced care plan discussion. So you can talk to Jackie at the Coast, at the Greensleeve table. She was a big part of helping to develop that.
Let's go on to, this is back on over to you, Carmen Sombrowski, your opinion of online wills and whether or not those will-making kits are legitimate, married, no children, no blended family, if it's just a simple will, and is it something that would be able to navigate some of these conversations?
So remember the disclaimer. It was one of the few slides I managed to get up. The online will forms may work in limited situation. It's kind of like if you check online, if you've got a little cut on your hand, do I have to go to the doctor? No, I'll check online, I'll get a Band-Aid. If you've lost your arm You don't check online, you see a doctor. Well, it's a similar kind of thing with the online will form. There are certain rare circumstances where an online will is better than no will. If you are doing an online will, representation agreement, anything, follow the instructions. Because most people do not do the forms properly, they don't date it, who's the executor, they don't understand what the forms are saying. If you have a blended family, I do not recommend the online form. If you have any beneficiary where they shouldn't have the money outright, I do not recommend the online form. So mom and pa own a house, it's now worth $1 million. You fill out the online form, you die, your child gets $1 million the day they turn 19. That may not be the most effective planning. It may not be in the best wishes for your child. If you have an adult, whether it's a child, a spouse, that has any kind of disability, you need any kind of trust, online wills aren't good. If you have significant assets and you need some form of estate planning, the online will may not be the optimal. So, very long-winded answer. In very limited circumstances, absolutely fine if it is filled out properly. But as soon as you have any kind of assets or any kind of situation that isn't kind of the Leave It to Beaver family of the 1950s with the same net worth of the 1950s, I recommend you see a lawyer to have your will done.
Amen. Okay. Chloe and Anish, your partner in solutions, there's a few questions about sort of what is the role of a social worker in the hospital or the emergency department, and can a healthcare team or social worker override a family's decision? What's your role and how do you interface when there's many variables to consider?
Good question. I don't know that I have a really straightforward answer because it's actually really hard to kind of lay out everything that we do as social workers. It could, like, honestly, there's a million different things depending on the day. Being in hospital, I guess that was the question, a social worker in hospital. That is, I mean, being a big part of the care team, knowing what's going on with different patients, we would get referrals. People can ask to speak to a social worker if they had questions themselves. So it could be questions like advanced care planning, just trying to have help navigating what's going on for them, because having just gone through it in my own family, and I work in healthcare, and I was like, ugh, this is wild. You need to have advocates. You need to be able to absorb the information, write down the information. And I think sometimes it's just not happening. And so to have someone to sit down and be able to go through step by step what's happening. We can't predict the future, but we can certainly say, in other situations, I've seen A, B, and C happen. And so these are things to maybe prepare for or maybe to consider. We also get called in when there's these ethical issues or like very complex family dynamics. Abuse, neglect, and self-neglect is also a hot topic. So if there's any concerns, someone gets brought in by emergency health services and they look disheveled. It looks like maybe they're not eating well. Their house was a mess. Right away, social work referral. Can you fix that? So, that's sort of in the general wheelhouse of some of the things we might do in hospital. Community isn't that much different, but we tend to have sometimes a little bit longer relationships with folks just because of the nature of community versus hospital. In community, I work closely with case managers, the rehab team, LPN supervisors. And so we would consult with one another, especially if there's complex situations happening. And sometimes people would say, well, what's your perspective from an ethical social work perspective? And I can sort of work with them and provide some feedback.
Fantastic. Thank you and Anish both for what you do for our community. I know that the Hospital Foundation and our friends at the Auxiliary have been very supportive of your Compassionate Care Fund, and we thank the Auxiliary for carrying on with that really important work, because oftentimes you're doing the healthcare and the medicine that might not be inside our hospital, but definitely plays a big role in the determinants of health. So thank you for what you do. We had a lovely note, and I have to read it because it actually echoes what I was feeling at 5:48 this morning. I had a reaction of horror and terror and a lump in my throat even getting to this door. Is this normal? It's all taken time to sit and listen and feel better now about having these conversations, whether it's Western society or just our inability to think about the end. It's so nice to be able to have a community of supportive people. So, Lady Kim, in your realm of ethics, why is it that we have a hard time as a society discussing our wishes in the end?
It's a really great question. I think it's, again, just goes back to our norms and our society of the culture that we've grown up in. You know, we tend to be a little bit more focused on, you know, technology and innovation and all the exciting things we can do and improvements. And it all is extremely exciting, the use of AI and other, you know, new innovations that may lead to, you know, further therapies and, you know, more of a curative model and focus. And that absolutely should never go away. But we also do need to recognize, and I think we are starting to, and I think one of the, like I throw up those stats from the report, since COVID, there has been a bit of a shift, I think, in recognizing all of our mortality, no matter what age we are. We're all facing it together. It might be on a different, you know, timeline, but we all come into the world, we all must exit the world. So starting to actually have a conversation and reflect. I do see a shift in the last few years, and we see that with those numbers increasing, that we're having these conversations because we sort of were forced into it with this kind of more global, you know, pandemic of looking at, oh, wow, there's some serious threats here. So I think it does take those moments to reflect on, well, what is important to me and what not. As I said, I think we still have a ways to go because there still is that more curative model and focus on technology and improvement. While at the same time, we do want to be realistic with the fact that, you know, at some point, we do have some decisions to make. So it's not just about quality of life as we're living, but what does the quality of end of life mean to you? What would you like to see? And those are hard things to face. And I'm with you, most people on that too. It is hard. But important for us to think about, you know, what is most meaningful and what does that quality of our end of life experience, as well as, or however many long we may have, to ask ourselves. But thank you.
That actually transitions nicely to the next question. This is for Dr. Guja. At what point of a palliative diagnosis does Dr. Guja and her team recommend a referral to palliative care services? And should I be letting my GP know of my advanced care plan?
Wonderful questions. So the first part of that question, I think our family physicians here actually are really well versed in palliative care and do a good job. So they're always, and our nurse practitioners as well, they're always a first stop to have these conversations about palliative care, what it is, what it would mean to you. When to start having that conversation, I think a good opportunity is whenever you're diagnosed with potentially a chronic illness that we can't cure, that's going to get progressively worse over time, that's going to shorten your life, or in the case of more severe, serious diagnoses that are life-limiting much more quickly. So things like, you know, stage 4 cancers and that kind of thing. But other diseases, like I'd mentioned before, the more the chronic illnesses that take longer for a decline, those are things like lung disease, like COPD, congestive heart failure. So those kind of illnesses are reasons to have those conversations about your wishes with your family doctor, your nurse practitioner. And then any time that there is a change in your health, so say you're going along, you have lung disease with COPD, and you end up in the hospital a few times in that year, and you need more oxygen at home, you can't do the things you used to do. Anytime there is any kind of change like that, it's an opportunity to reflect and have that conversation again. And I think this was mentioned by one of the panelists earlier, is just having a discussion about your goals of care, about palliative care. It's not just a one-stop shop, one conversation. It's an ongoing conversation that will continue for weeks, months, years, as your condition changes, as your wishes might change. So yeah, I think anytime you have a diagnosis of a serious illness, a life-threatening or life-limiting diagnosis, it's a time to start talking about palliative care. Even if you're focusing on treatment or cure, palliative care can still be in the background, making sure that you have good quality of life when it comes to your symptoms. So say you're getting treatment for your cancer, but you're having awful nausea. So palliative care can come in and help to treat the nausea, even though you're still getting treatment for your cancer. As that trajectory goes on, maybe that treatment didn't work, or maybe the side effects from the treatment were intolerable and you're done. You don't want to focus on that anymore. Then maybe palliative care actually becomes more of a focus, and we're not so much focusing on keeping that disease from spreading or stable or trying to cure it, but we're trying to focus on quality of life. And then kind of right at the end, that last stage of palliative care is hospice end-of-life care. So my recommendation is have those conversations early and continue to have them throughout your life and illness. I forget the second part of that question. Sorry.
I think you already answered it regarding ensuring people let their GPs know of their ACP.
Yeah, definitely.
Always good.
You need to know. Yeah.
Always good. Back to you, Carmen S. What did you mean when you said you cannot delegate MAID?
So with a Section 9 representation agreement, you can delegate or authorize somebody else to make decisions for you. And with Section 9, it's not only authorized, but they can assist you in making decisions. So if I have a Section 9 agreement and I don't have capacity, I've delegated or I've designated Carmen to be my representative. She can say where I'm living. She can say who I associate with. She can say what programs I'm going to take. She can say what I'm going to eat. She can say what I'm going to wear, and that's good because we have similar taste. But she can make healthcare decisions for me, major and minor. She can instruct a doctor to terminate life support. But I cannot say, Carmen, you are going to make the decision as to whether I am going to have medical assistance in death. That decision has to be made by the adult, and there's a number of tests, and it's not the subject matter of this talk, but there's capacity tests, and there's capacity when the procedure is instituted, and that the adult meets all the tests and the requirement, and then before the MAID actually occurs, the adult again has to have capacity and again has to consent to the procedure. So Carmen can't make that decision for me. I have to make those decisions. And that's what it means. You cannot delegate the decision for MAID.
Okay, there's a few questions that actually will be answered when you fill out your green sleeve. And so there's a question about organ donors. There's a question about pets and whether or not they need to be appointed for a caregiver should you not be able to care for your pet. And there's also a few things in the emergency binder that Chloe referenced, and we have a couple to award to the crowd here today, regarding passwords and loyalty program points. Ooh, those are the easier ones. Just make sure that you read the guides and the information and document that in a place that a loved one can find and hopefully take care of based on your wishes. And then there's a question regarding green sleeve. Is it recognized in the greater Vancouver area and throughout the province?
So there are different health authorities in the province. Fraser Health is kind of the big, I feel like they started things off and took some advice from Alberta with their green sleeve program. Vancouver Coastal Health, the North Shore has a green sleeve program, and we have one as well. So it is recognized within Vancouver Coastal Health and Fraser Health, but I can't speak to the other health authorities in the province. And it's definitely not a national program, unfortunately. I wish it was. But I think the other thing to keep in mind is that the documents within your green sleeve, if you have your representation agreement in there, your advance directive, that would, those are all legitimate and valid across the entire province. Tell me if I'm wrong about that. No? Okay.
And while you're there, Carmen, can you say a bit more about the role of the ambulance and emergency health services team? How do they interface with the green sleeve and the emergency department, for that matter?
Yeah, so our paramedics were a big part of helping to develop the Green Sleeve program. And often they are the first people of the healthcare team who encounter these situations that we've talked about so much today. So like the example Chloe gave with a man found down at home, the paramedics, the first one there, first one called. And how the green sleeve worked is that there's a green dot, a green sticker that you put on your door, or you put it on a cupboard somewhere that's easy to find. And that way, right away, the paramedic knows, hey, this person has a green sleeve. If they can't speak for themselves, I know I can go look through that and I'll know what their wishes are. Because if they don't have that, by law, they have to try to keep you alive, prolong your life, even though that might not be your wish. So again, a gift to all the healthcare team members, a gift to that paramedic is actually knowing what your wishes are beforehand. And then in the ER, I recommend that people bring their green sleeve with them to the hospital so that it can be looked at by the nurses and the doctors on your team so that they know exactly what your wishes are. And this is if you can't speak for yourself, right? That's what the green sleeve is for. If you're up and talking and it's not a problem, still nice to have in case something changes during your hospital course, but your voice always comes first. And if you have lost your voice, then the roadmap that you've made out within the green sleeve and the documents there can be used by the whole team and your decision makers in the hospital.
Excellent. And Kim, I think I overheard you say this morning that one of the first places that emergency looks for is in the patient's record, is it? So with your health number, if you have stated your advanced care plan, it can be registered on your personal health record? Did I get that right?
Well, what I was speaking to, I think this one, now it's all foggy, all the different meetings we've had today. But I think what I was speaking to, actually, what I wanted to jump on that point is I actually became aware of a provincial initiative that the advanced paramedics for the EHS, Emergency Health Services, have started as a pilot project. I just don't know how far the reach is if it's become part of the Sechelt community. But they're actually training their advanced paramedics in palliative care and having these conversations. And that's what they'll do. They can go in and look at the chart. If you've been designated, especially a palliative patient, they will send out these advanced paramedics who have this special training and how to support you at home in an emergency situation. And they can review, what your wishes are. And if you want to be hospitalized or if you change your mind, which is what happened in my loved one's situation, where they were uncertain where to go and they were nearing end of life, had a medically distressing event. And I have to say it was the most impressive, really it was a goals of care conversation and advanced care planning, which is something that you have your advanced care plan inform your goals of care. Those were visiting, here's what your wishes were. Is this still consistent? And we can take you to hospital and this is what might happen. but we can also support you at home with home oxygen, medication management until your palliative care physician comes the next day. And that's what happened. And they were able to go in and look up the medical records and see, oh, here's what, yes, you're palliative, but also here's what your wishes were, and revisit that. And I was incredibly impressed. And it took a personal experience for me to, someone working in the healthcare system. But again, that's going to be a provincial program that is, I think, slowly training different EHS. I don't know, maybe Dr. Gougeot, a little more locally, if that's if the paramedics have been trained in these programs.
My understanding is that yes, that we do have paramedics that have been trained in that. So we're very lucky.